Professor David Jacob Rawat, who is a clinical professor, pediatric gastroenterologist in SKMC Abu Dhabi. And he'll be talking on a very important topic, multidisciplinary team, which we all require for everything almost. And he'll be talking about Aerodigestive Clinic SKMC experience. Welcome, floor is yours.
Thank you, Mr. Chairman. I'm delighted to be standing here, and it really gives me a great pleasure to be here presenting our SKMC experience of our multidisciplinary team, the Aerodigestive team. I just want to add that we have today, there'll be five of the seven of us will be, six of the seven of us will be presenting today. Dr. Basha, who is an ENT surgeon, is on his way from Dubai. Hopefully he'll be on time. Collectively, and I'm very proud to say this, our multidisciplinary, meaning our multi-professionals, the speech and language therapists, the dietitian, and a respiratory technician, between them have more than 50 years experience. So we're talking about a very experienced team. I'm very proud to be part of this team. The first speaker who's really been instructive and instrumental in setting the whole clinic up is Dr. Sofia Konstantinopoulou. She is one of our international representatives. We're represented from Greece, Ireland, Philippines, India, Sudan, United Arab Emirates in the team. Dr. Sofia is trained, and she's American board trained. She was assistant professor in Pennsylvania and is now adjunct clinical professor here at Khalifa University. Sofia.
Well, thank you so much, Dr. David, for the kind introduction. I think he made all the team feel kind of bold by adding up the years of experience. So without further ado, I wanted to start our talk, which is going to be in two sections. The first section would be discussing the Aerodigestive clinical care model as described in a consensus statement in a landmark paper published by the US. And then the second part gave a brief experience with regards to our own centers, patients, and what we're trying to put forward. I have no financial or other disclosures to make. So we know that recent advances in the care of critically ill children have created a population with ever-growing needs. And these children have chronic complex conditions affecting multiple systems. And we know that the care of these patient population is actually costly as well as complex. These children depend heavily on technology. They also need to see a multitude of specialties in order to have appropriate care. They have frequent admissions and they do require often a lot of procedures. So caring for such chronic and challenging pediatric patients actually demands that we try to deliver an effective and consistent care that is outcomes driven, that is patient centered and family focused. So with regards to the consensus statement as to what an aerodigestive clinical care model, actually the authors of the landmark study published by Bosch in 2019, they actually surveyed 33 physicians from 11 different aerodigestive centers with regards to the location, the structure, as well as the years of operation. And so they delivered what is called the Delphi method, and this is an iterative questionnaire-based method adapted in healthcare that seeks to reach consensus with regards to 4 different domains. And one of them is the definition of what is an aerodigestive patient, and then secondly, what is the construct and the functions of an aerodigestive clinical care program, the identification of the research priorities, and then future directions and research outcomes. So the consensus was reached when there was a supermajority in the 36 items of greater than 75%, or when there was no change in the median ranking score in the 33 out of the 36 items of the questionnaires. And then the questionnaires' response rate was quite high, ranging from 97 to 100%. So starting with the very definition of who is an aerodigestive patient. This would be a child that has a combination of either congenital or acquired conditions that affect in various degrees, either the airway, the breathing, feeding, growth, and or development. So for instance, imagine that you are now the pediatrician on call and it's RSV season, And you're called to the ED to admit a patient who's a former 32-weeker who had a prolonged NICU course. And the patient initially requiring prolonged intubation, then weaned from mechanical ventilation to high flow nasal cannula, eventually sent home on supplemental oxygen and diuretics, and having a course that's complicated by pulmonary hypertension on sildenafil, as well as having a history of dysphagia and failure to thrive, for which the patient is followed by Ped-GI nutrition and has been kept on NG tube feeds. So this would be kind of a perfect example of a patient coming to the Aerodigestive Clinical Care Center. So some of the common conditions I alluded to have to do with problems in the airway, such as, for instance, patients who come in with noisy breathing, such as stridor or recurrent croup, patients who have vocal cord paralysis, patients who present with problems with regards to the lung parenchyma, such as patients who have recurrent lower respiratory tract infections, chronic aspirations, chronic lung disease of prematurity, other patients who have a tracheoesophageal fistula with or without esophageal atresia, patients who have failure to thrive, as I alluded to earlier, poor on G-tube feeds, and so forth. With regards to what are the essential core members of such a center, on the left-hand side, you see that they are focusing primarily on the ENT services. And ENTs are crucial because they are the ones who actually do the airway assessments with the microscopic MLEs. They're the ones who do the upper airway surgeries, as we'll see in a moment. They're the ones placing the tracheostomy tubes, and they're the ones who in the centers do FES procedures, which is the fiber optic endoscopic evaluation of the swallow, along with the SLPs. And then you see that the SLPs are also very crucial because they're the ones who do the bedside assessments and the ones who actually do the testing, the FES and the video fluoroscopies, in order to identify the presence and severity of dysphagia. And they're also the ones who ideally provide a feeding therapy in the plan. Then we see the essential role of the GI team. And so you do optimize the reflux medications. You want to optimize the children's caloric intake and nutritional support along with the help of the nutritionist. And then, of course, you do see that there is a pediatric pulmonology there involved. We're the ones that typically tend to pick up these kids, either referrals through, for instance, our NICU colleagues or through the emergency department, through our inpatient consults on the floors and in the ICU, or our, for instance, cardiology colleagues and so forth. And we're the ones who try to assess their respiratory status, kind of assess their needs, and then optimize their respiratory status in order for these children to improve in terms of outcomes, but also to be ready for any procedures that the patients would be undergoing under a general anesthesia. And so we do make sure that we communicate with the teams and coordinate care so that to avoid any adverse outcomes with that regards. Very important is the presence, of course, with nursing and our clinical care coordinator. The clinical care coordinator is the glue that brings all the members together and then communicates the plan of care effectively as to what the future steps are with the families, that with regards to further imaging and labs when that needs to be scheduled, or to procedures and elective admissions. And they're the ones that often let us know that a child has been ill and is being referred to medical care, and so that we look after that child and consult on them when they're inpatient. There's also a magnitude of other actual specialties who can be of great assistance with regards to this. And we saw in the previous talks the importance of having interdisciplinary care, whether this has to do with foreign body removals. For instance, we could also have other people joining this digestive clinical care model, such as pediatric surgeons, for instance, pediatric cardiologists if needed, peds neuro even for our CP patients, anesthesiologists, specialties with regards to sleep medicine. And of course, we should never forget the role of RRTs, as Tina is going to show us later on, because they're the ones that do the clinical assessments when a child, for instance, has tracheostomy. They help us adjust the vent settings. They're the ones assisting us with regards to procedures in the OR, such as our flexible bronchoscopies, the bronchoalveolar lavage, and bronchial brushing. And they're the ones also who help us with pulmonary function testing, and also the sleep techs who are RT trained often are the ones who run our sleep studies in the lab. So these would be the essential sort of steps of what the aerodigestive clinical care model would include. And so we start with a care coordination, identifying the patients. We do a pre-visit intake where the care coordinator, the nurse, and myself would call the patients. We do pre-scheduled appointments where they come and meet our team in a shared clinical space. Oftentimes, there is room to have a combined procedures such as a rigid and flexible bronchoscopies in addition to an upper endoscopy with biopsies, it would be the triple scope. And then we do a wrap up with the family and an after visit summary. And we want to make sure that these patients actually, we follow them longitudinally and we see whether they graduate from the program. And so, for instance, we have a patient who had a vocal cord paralysis. And so that patient, eventually she had a tracheostomy, and then eventually after undergoing a procedure with the anterior vocal cord lateralization, she was eventually decannulated, and so she graduated our program, and now she's tolerating full feeds and she's growing nicely. And so we want to do also operational meetings with regards to where we stand with our patients and our procedures and the things that we can always improve. So the important procedures of a program as such that an ENT surgeon should absolutely be able to perform conveniently would include things that have to do with increasing the upper airway of the cartilaginous skeleton of the airway. So this would be often in endoscopic procedures. That would be instances like layered tracheal reconstruction. It may be endoscopic treatment of upper airway obstruction. So here would include things that alleviate upper airway obstruction, such as when the patient has choanal atresia, for instance, and that needs to be repaired. Simpler things like adenoidectomy, plus minus tonsillectomy, or removal of lingual tonsils, for instance, tongue base reduction. And Dr. Bashi is going to show videos of such things later on, I'm sure. And then they also have to be able to do procedures with regards to treating aspiration, like the before mentioned patient who had vocal cord paralysis, and also other procedures to improve voice, and of course, tracheostomy tube placement. And as shown earlier with the GI tract, it's very important to be competent when it comes to foreign body removal. For pediatric pulmonology, the essential procedures that we're able to also follow in our center would be performing flexible bronchoscopy with bronchoalveolar lavage, being able to perform bronchial brushing for the patients with primary ciliary dyskinesia, being able to assist with regards to fiber optic intubation, and when we do the drug-induced sleep endoscopy DICE procedure, which is there in order to be able to identify any upper airway obstruction that is beyond the level of tonsils and adenoids. And that's been used increasingly in certain patients with residual obstructive sleep apnea. So the ones who have residual disease and need further surgeries. And then we should be able, and as we've done in the past, to assist with identifying the presence of tracheoesophageal fistulas. And so, for instance, we had patients who had come in with TS that was operated on, and there was a residual pouch that we discovered during our flex bronch at the distal end of the trachea. And so we had methylene blue installed, and when Ped-GI was there, they saw that there was hopefully no communication between the respiratory and the GI tract. And we were also able to bring on board surgeons so we could show them in real time what that looked like. So they have a clear views of the patient's condition. And then we did also bring a C-arm and installed radio pack liquid so we could see whether under fluoroscopy there would be a clear communication between the respiratory and the GI tract. And thankfully that was not the case. But this sort of helped bring all the people together in one room and discuss the case in real time and formulate a concise plan of care that we could deliver to the family. For the GI procedures, I know that you were able to perform a lot of things, upper endoscopy being one of them, and biopsies, as well as PEG tube placement in our center. It's been done. Dr. David will talk about it in a moment with the help of Ped-GI and PEG surgery as well. And then motility studies, obviously pH and kidney probe, and a lot of other things that are essential in the function of such a center. So the importance of having actually a concise plan with regards to what the future steps are in evaluating such patient with their imaging is that you avoid and minimize procedures that are not technically necessary to be done. Like I've had patients that I met before who may have had, for instance, video fluoroscopies in the span of 6 months, every almost 2 to 3 months, ordered by different people who were working independently and not necessarily coordinating care with the teams involved. And so I think the idea here is that you have a concise plan, that you try to minimize exposure to radiation, unnecessary medical costs, and you try and minimize, in the case of combined procedures under one anesthesia, the risk of procedure itself, like all the respiratory and non-respiratory complications, In case of the triple scope, you try and minimize healthcare costs because you allocate a specific OR time to do all these procedures. You minimize medication use and personnel. And then hopefully there's indirect costs, which have to do with the fact that these families now coming for procedure. And so they have all of these procedures under one, and they don't have to take more time off of work. They don't have, for instance, kids to miss school. They don't have to find alternative, babysitters for the rest of their kids. And so hopefully this has been shown in several papers that when you have a concise, efficacious, and centered care, that you do minimize indirect and direct healthcare costs. And you do improve outcomes with regards to intraoperative risks and post-op risks. So the conclusions would be that there is a definition of the aerodigestive care patient, that there is a specific structure that can be followed, special teams together working, special competencies of those people brought together. And then, of course, this is something that the future should be something to work on. This is not a one and done thing. And this is an ongoing process where we collect more data and we follow the patient longitudinally, and we define special care outcomes as well as research goals and quality improvement projects. So for our own center, we were able to go back and see for the first 6 months of operation, analyze retrospectively the charts of the patients who were seen in clinic. And so we included all of them between February and July of 2019. We collected demographics, psychometrics, and so forth. And so we see that a majority of the kids were younger, ages 1 to 5, which is no surprise, as they're the ones complex care needs and are going to have lots more complications those first years of life. And they had tracheostomy in a third of cases, and 2/3 of them had enteral feeds. So they were either NG, NJ, G, or GJ tube dependent. And the majority of them were Marathis, and then half of them did have 24 hours of home nursing, which points to the fact that they indeed had complex care, either requiring continuous overnight feeds or being trach dependent or trach vent dependent or non-invasive ventilation at home. So of all the patients, they carried multiple diagnoses, and they were followed on average by at least 8 providers prior to coming to the Aerodigestive Care Center. And that speaks volumes to their complexity and multiple care from specialties needed. The majority of the patients had as comorbidities prematurity, followed by congenital cardiac defects and then cerebral palsy. And the majority of the patients actually, a percentage of them had also genetic disorders and metabolic disorders, which are often quite seen in our clinic. And then a lot of the patients had undergone separate procedures, as you can see. So half of them, for instance, may have had a flex bronchoscopy for one way or another, or they may have had in a quarter of the patients an upper endoscopy or a rigid bronchoscopy in 1/5 of the patients, but only 20% of them had a triple scope. And so we tried to put forward, in the future directions, we are in the process of collecting the data for our center and putting it forward as to the span of the years of working. We have identified 120 patients that are new or follow-up, and we're collecting the data before and after entering their digestive program. So our hope is to inspire other people in the room, and I'm sure that Al Jalila and other hospitals may have similar models of care to target outcomes and disease specific, and also to develop, like you were mentioning earlier, about the foreign body specific care pathways that are validated, and to standardize all of our diagnostic procedures. We want to offer a quality of life questionnaires, and we have that as part of our data collection, both in English and in Arabic, so we can really truly see whether what we claim to see in our patients is true. So we want to see patient satisfaction. And then we would like also maybe one day to offer training opportunities for people that rotate, such as our GI fellows, come into their digestive clinic, be part of that, be part of the procedures and multidisciplinary care. And eventually, why not open a roadmap to network either nationally or even internationally, and much like other diseases have done, such as primary ciliary disease, dyskinesia foundation, or the CF foundation, or child cohort. So without further ado, thank you, and I'd like to pass it on to Dr. David, who's our next speaker.
Thank you, Sophia. If you look at the anatomy of the gut and the pulmonary, the airways, you can see that they're close proximity. It's not surprising that you have children with neurological developmental delay, but you're going to have disorders affecting the aerodigestive tract. This is reflective in the prevalence, and we know this anyway, that children with neurological or who are neurologically challenged clearly have a much higher incidence of gastroesophageal reflux disease, and indeed foregut, hindgut, and midgut dysmotility. So what's the role of GI in the aerodigestive clinic? The most important role, of course, is to diagnose or refute diagnosis of gastroesophageal reflux, or indeed supraesophageal reflux, supraesophageal reflux, meaning reflux beyond the esophagus, which may compromise the airways. We'll discuss the challenges of detecting supraesophageal reflux, which is very difficult to detect, to be fair. And mostly we'll be talking about impedance pH, which is very important in this particular group of patients, as I say, to make the diagnosis of gastroesophageal reflux disease. We very rarely have to use motility investigation, but some of them may have this motility warranting manometric studies. Our other important role, along with the dietitian, is to, of course, ensure adequate nutrition, and also to reduce nutrition if they're overweight. And of course, we have a role together with the surgeon for inserting and for feeding devices. So if you look at the pathophysiologic mechanisms behind reflux, there's the reflex theory. The reflex theory is, of course, you have, it's a common embryonic origin between the esophagus and the bronchial tree. So chemokines can induce airway or disease, which are vaguely mediated. And then the reflux theory, which is, of course, contact of the esophagus with gastric content. And of course, the manifestations, as you all know, go beyond the esophagus and can affect, indeed, ENT, so you can get pharyngitis, laryngitis, dental erosions, sinusitis, and of course, affecting the airways. So what are the diagnostic options and what are the diagnostic modalities that we have? Sometimes we empirically just give PPI, which of course, and monitor for response. And most of the patients will be on a PPI, probably long term. And of course, our job is to make sure that that is adequate enough and suppressing the acid enough to prevent any complications. Or indeed, if it's normal or if they don't have reflux, just stop the PPI, because we know about the long-term adverse effects of prolonged PPI use. We want to take upper GI contrast studies, which are find the anatomy, and nuclear medicine scintigraphy can be very useful in for upper GI motility. And of course, endoscopy, which is part of the triple airway assessment. I'll spend some time talking about pH and impedance because this is probably the most important of these studies, particularly in this cohort of patients. So radiology, we use radiology really to exclude or really identify any anatomical defects. This is a hiatus hernia. This is pyloric stenosis. This is actually a child who had a pyloric muscle that was Botoxed, and he responded very well to. That was vomiting. Again, malrotation. And here, the strictures. Important to know before you go in with endoscopy. Scintigraphy, these are milk scans, and particularly useful. You can see here, this is a so the technetium labeled milk, and you see here, this is uptake. It's a nuclear medicine study, so it's no radiation. And you do delayed films, and you see there, you've got an acid, the pH is 4, and you have reflux. You can see here uptake in the esophagus. If you do a delayed film, you may find technetium or labeled in the chest, which may signify aspiration or confirm aspiration. Gastric emptying, again, we can more formally assess whether the stomach is emptying adequately or not. And as you can see here, there's delayed gastric emptying in this patient with foregut dysmotility. So esophageal pH monitoring, so this is the most, I suppose it's the gold standard for detecting acid reflux, and there's different mechanisms we use. It's a good study to use because it's over 24 hours. It assesses postprandial episodes, and The main problem with pH studies is that it won't detect any alkaline reflux, and it's uninformative about the height of reflux or the duration of reflux state. So indeed, we've moved to using the multi-channel intraluminal impedance, and this is a measure of the opposition to electrical activity between two electrodes, measured in ohms. It's multi-channel, so you can see here in this patient, you can see the oronasal flow with the chest wall movement, and you have a reflux episode, which is indeed alkaline, the pH of 5.4. It's also useful to correlate symptoms with reflux episodes. So in this patient, you see there's a cough, which is followed by a reflux episode. You can also detect supragastric belching in patients with aerophagia. In this patient, particularly aerophagia, who responded very well to baclofen. What about endoscopy? We use endoscopy, of course, to more objectively assess the gastroesophageal reflux disease. And of course, you can see there's different classifications macroscopically. And to exclude any other pathology like eosinophilic esophagitis, for which you need a biopsy diagnosis. And these patients present with dysphagia and feeding difficulties. Important also to identify other pathologies. So these are patients who, in your left-hand side, you see there, this is a patient with Barrett's esophagus, which we do see. I have 4 patients at the moment with Barrett's esophagus who have, again, had chronic reflux which has been gone untreated. The second is a patient here, you see here with a little stricture, which is dilated. And again, these are all detected at the time of endoscopy. Important also to recognize, so you see here on the left-hand side, the complications of chronic PPI. This is a patient who was 12 years old, who had been started on high-dose PPI, and you see these polyps in the antral and fundus, and this is parietal cell hyperplasia if you biopsy it. Also important to recognize normal mucosa. This is normal mucosa, which of course in the child who was on PPI, we stopped. And it's important to do this. If you don't have reflux, you stop the PPI. So in the future, we have these. This is called Restec, which is a more a novel, I suppose, diagnostic modality for looking for nasopharyngeal reflux. It's a catheter which assesses for pH or aerosol pH in the nasopharynx. And here you see again acid reflux or acid reaching the hypopharynx, indicating that the supraesophageal reflux disease. Pepsin, this is another novel modality called the PEP test. You may recall before we used to use litmus paper in neonates to see if there's any acid reflux. And this is a similar, I suppose, analogy or concept of looking for pepsin from sputum. And there's some studies ongoing now at the Royal London, which we'll hope to see the results of in the near future. The non-invasive way of testing for supraesophageal reflux disease. So what about dietetic assessment? Of course, this is part of integral part of our assessment in the Aerodigestive clinic. They all undergo a dietetic assessment, including anthropometry, which is recorded, nutritional bloods, and of course, often many of them need feeding devices, like this child you see on the left-hand side who had a laparoscopic insertion of a gastrojejanostomy, and you see the significant weight gain post-insertion of enteral feeding device. So at SKMC, we do a primary laparoscopic insertion of PEGs and Ped-GI tubes. This means it's a primary button device, which means it's only one procedure, not 2 procedures like previously where we did an endoscopic placement and then converting that to a button later. This was our experience, which was very eloquently published by Rana Ahmed, our 9-year review of our experience with the percutaneous endoscopic gastrostomy, which is laparoscopically assisted, a single step. And this is what it looks like. You see here, sometimes for the jejanostomy, we do primary. For those patients who have gastroesophageal reflux disease, we do a primary gastrojejanostomy, which is basically laparoscopic assisted primary button device with the assistance of the interventional radiologist at the time of surgery. So it's all done as a one-stop, single-step laparoscopic insertion of a gastrojejunostomy, diverting the stomach. This is the team, which you all meet most of them today. The next speaker is Dr. Sona. She's a speech and language therapist who was born here in UAE. She trained in South Africa and has more than 15 years of experience with pediatric speech and language therapy, with particular interest in dysphagia and feeding difficulties. Sona.
So I'm happy to be here to be talking to you about my role in the special MDT clinic, which unfortunately happens only once a month. So what do I do as a speech language pathologist in the Aerodigestive clinic? So the main goal for me is to reduce the risk of aspiration and ensure safe oral feeding and thus protect the airway. So because these patients have complex or multiple diagnoses, there's always a tendency that they would have some kind of swallowing problem, either dysphagia, or we're looking at feeding issues like an oral aversion because they've been on tube feeding for multiple years. So my main goal would be, can we feed the patient first of all, and if at all we can feed them, can we feed them safely, thus they don't develop any aspiration pneumonias, and also to attain adequate nutritional intake by moving from tube feedings to oral feeding. Is the patient getting enough nutrition, or should we still give some kind of support for the tube feedings? And also to educate caregivers regarding safe oral feeding and the feeding strategies, because I know what I have to do with the patient, but do the parents or the caregivers know what they have to do? So it's not just about clinically assessing or managing the patient, it's also about educating the parents and the caregivers so that they do it the right way at home. And some of the most common cases, so we assess and follow patients with dysphagia, which is usually an associated symptom in the MDT clinic. And it's mostly patients with pharyngeal dysphagia. So they may have a tracheostomy, or they have without a tracheostomy, they would have other issues, some muscular issues like a patient with cerebral palsy or a patient with Down syndrome, where they have hypotonia, thus leading to swallowing problems. And this patient usually is, we would do a clinical swallow evaluation or a bedside swallow evaluation to see whether we can identify at bedside or in clinic if this patient is safe for oral feeding or not. Or most of the time, I take them for something called as a modified barium swallow study. It's an instrumental swallow evaluation to assess the tracheal aspiration or laryngeal penetration during oral feeding, and also to identify which food texture or which liquid consistency is safe for the patient, because we don't always jump into thin liquids. We may have to thicken the fluids for the patient. So this is what is usually done by me in the multidisciplinary clinic. And then we follow up. So can you play that video? How do I play this? So this is just a quick video of what we look for in the video fluoroscopy. No, can we play that? Is that working? Okay, so it's just a video about what I look for in the modified barium swallow study. And what do we do in the MDT clinic? So we decide whether this patient can be fed orally based on the instrumental swallow evaluation or my clinical swallow evaluation. Should we feed or shouldn't we feed? And if we decide that the patient is not safe for feeding, then we, as an SLP, we will start on we start or continue enteral feeding. If the patient has been on oral feeding, we shift them to enteral feeding. And then we see to it that we follow up with non-nutritive stimulation so that in future, hopefully when the patient is ready to eat, this patient has not developed any oral aversion and is slowly ready to accept any kind of food or liquids later on in life. But if we identify that this patient is safe on a particular food texture or liquid consistency, then we start with dual feeding on the approved consistency by the physician. So if we agree that the patient is safe on honey thick liquids, we gradually introduce the honey thick liquid and gradually wean them off from the enteral feeding. And the caregivers will be educated regarding the oral feeding including the use of thickener powders and the feeding strategies. And follow-up, I see to it that I follow them up regularly in my clinic because, as I mentioned, the MDT happens only once a month and all patients may not be seen every month in the MDT. So I follow them up in my clinic to ensure that the patient continues to have safe oral feeding, gradually increase the oral feeding, that could be liquids and solids or solids, and weans off from enteral feeding in a safe manner. And the patients will be seen in the SOP clinic as required, maybe once every week, maybe twice every week, once a month, as and when required for them. Thank you.
The next presenter is Fatima. Fatima is Fatima Mohammed. She is a pediatric dietitian who has, as I said before, more than 19 years experience in pediatric nutrition. And we're very, very honored and very pleased to have as part of our team. Fatima.
Left and right.
Thank you, Dr. David. It's my pleasure to be with you as a MDT clinic, and thank you, Dr. Mikdadi, to give us a chance to be presented in this conference. So my objective as a clinical dietitian in MDT clinic is to know exactly what is a Aerodigestive clinic, as we know, it's mentioned previously. What is the role of clinical dietitian mainly in the MDT clinic, and how clinical dietitian will be helped and why it's important. So as we know that Aerodigestive clinic, it's a multidisciplinary clinic that include all specialty that needed to treat the patient clinically from each specialty. As a dietitian, we have a specific thing we have to deal with the pediatric dietitian. So actually, from dietitian side, we know that how to deal with this patient according to the condition. So Aerodigestive clinic, as we mentioned before, it's a once a month clinic that we need to feed, that we need to meet all together to discuss all the patient at the team, and we can come out with a clinical intervention. So as it is mentioned previously, we have a feeding disorder. We have a feeding disorder as together we can treat all the different cases, complicated cases, such as developmental and neurological disorders such as autism or schizophrenia, or patient with a difficult swallowing, failure to thrive, poor weight gain, and patient dependently on the nasogastric and cannot feed properly through oral intake and dependently on the feeding G. So also we can treat the patient at the team for specific feeding disorder. So what our dietitian role in this feeding? As we know that it's a multidisciplinary team. Without dietitian, we cannot treat the patient or we cannot feed the patient properly. So the dietitian is qualified and health professional that focus on diagnosis, treated, and intervention to give it to the patient that have specific problem related to the nutrition. So mainly pediatric nutrition focus on the treatment of the pediatric to make sure that the patient get proper nutrition for growth and development. So we have nutrition care process that the clinical dietitian use, especially to diagnosis, to assess in patient. From assessing, we have used different categories, such as we can check in patient anthropometric data, patient history, nutrition history, medication, lab test, and that focus on, from all these things, what is the nutrition problem related to all these things. So in this process, we can use different growth chart, because as we know that we have different cases, we treat different complication patient. That's why we need different growth chart for each one, such as WHO, CDC chart, cerebral palsy chart, and Down syndrome to make an assessment. Also, we use the energy and protein requirement, different equation that we use it in nutrition care process that depend on the patient condition, such as the Scoville or dietary reference intake or catch up if the patient failure to thrive. So we use different equations to assess different patients. And all this protein and energy requirement, it should be specified according to the individual, such as what we have here for the Scoville, used for the different weight to height, how to estimate the BMR for different cases, for different sex and different age. Also, we use specific requirement for protein from infant to adolescence. So we use all these things. So we have different categories. Sometimes we will use with the Aspen equation or Aspen equation. So we use different cases and we cannot focus on one. According to what the disease we faces, it should be even individualized. So the next step of nutrition care process that the dietitian uses is diagnosis. Diagnosis is how to identify the nutrition problem from the patient chart, from the patient data available. And this should be with the B's. B's, that means we have to find the problem. What is the problem? Is the problem related to the nutrition? And we have to etiology. Exactly, is the problem come from the lab test? Is the problem come as a result of the lab test? Is the problem come from the symptom, sign and symptom? We have to check the patient even physically if there is any problem in physical activity. As Dr. David mentioned, if there is any symptom of GI reflex. So we have to come out with exactly the nutrition diagnosis, how it will come from this one. So we have two things here. We have to follow in nutrition diagnosis, which is faces mostly in the patient when we assess the patient. So we can use the BMI for age. So to categorize if the patient is a proper weight for age. As we mentioned before, we use different growth chart. From this different growth chart, we can mention is a patient on the proper health weight, or is a patient is a failure to thrive, to be underweight. So we have to come with a specific plan. Or if the patient is obese, by this category or this diagnosis, we can create a specific nutrition intervention. Also, the most common categories in the pediatric is a malnutrition. This is what we face here in our hospital mainly. So, and we have a specific procedure how to diagnose this malnutrition, even in the adult, not in the pediatric. And for the pediatric, we have a specific categories for this BMI to Z score, which is now working on the hospital. So we have to focus on what type of Z score or what type of malnutrition the pediatric or the cases in front of us is facing. Is a mild or moderate or severe? So by this nutrition diagnosis, we can come and identify from our intervention, how to intervene or how to provide what the patient exactly needs according to the problem. So we have to create a plan. We have to deliver a food according to what plan we faces. Also, we have to educate the patient, we have to educate the family, and we have to educate the family team also. So to feed the patient, as I mentioned, we have to come with a feeding plan. To feed the patient, it's not only the dietitian role to decide how to feed the patient. As Sona mentioned before, we have to check the patient if tolerated orally or not. From the GI, we have to check the patient how, if there is any malabsorption of this nutrient or not, which feed we can select it, and which way we can feed the patient. We cannot leave the patient without feeding. So we have different ways to feed the patient, such as nasogastric or gastrectomy or duodenal or jejunostomy feeding. So we have to find ways to feed patient with a proper plan. So this is what the formula we have in SKMC. We have different formula according to different cases that we faces. So the most important, we have standard formula, which is a lactose-free, gluten-free formula. And we have to select that formula according to the patient disease. If the patient have cow allergy, milk cow allergy, such we can use different formula. If the patient have any problem with the absorption, we can use different formula. So according to this, we can select specific formula for each one. So the monitor, as mentioned before, we have to determine and to measure our nutrition goal plan, how it's going. is it going according to progress what we need, or if there is any problem we have to face it. So to monitor the patient, we need to follow patient regularly to check the weight, the height, the tolerance, and to make sure if there is a standard nutrition indication. So the proper follow-up we have to be seen in the clinic, as we know that it's a once-month multidisciplinary clinic. So from our dietitian side, we need to check how our plan is going. So that's why we refer this patient to our regular pediatric clinic to make sure is the patient receiving proper feeding plan, to monitor overfeeding or underfeeding, to monitor weight gain, GI tolerance, and the lab test. So also sometimes we have faced some challenge from the patient, such as how to assess the patient. Most of the patients, they have tracheostomy or big feet. So it's difficult to assess the patient with this condition. So that's why we need to get proper assessment to get proper nutrition requirement. Also proper follow-up in the clinic as the outpatient. Sometimes we miss the patient according to some family reason. The other thing is we face also a problem with the patient, family, caregiver, how to adjust the feeding volume, the tolerance, the fortified. So we have a challenge things with the patient. In addition to also, there is a problem of demand issue or the follow-up issue for non-national patients. This is what we face in the clinic mostly. So the patient can see by the physician, but not applicable to see by the dietitian. So that's why we have helped them by other way. And this is my reference.
Thank you so much, Fatih. For the next speaker, I'd like to introduce our very own Tina Mendoza. She is a registered respiratory therapist who trained in the Philippines and has been in the UAE and specifically at SKMC for the last 17 years. So 19 years, I'm told. Okay, great. So she's the backbone, I think, when it comes to respiratory care. She's one of the most cheerful persons I've ever worked with. And she comes into work with the same joy, I think, as if she just started yesterday. So I think I want to hear from her about her experience in our Aerodigestive Center. Thank you, Tina.
Good afternoon, everyone. So thank you so much, Dr. Sophia, for the introduction, a very nice introduction. So as mentioned, my name is Maria Cristina Mendoza, and SKMC knows me by the name Tina, for short, because there are a lot of Marias in the world. So what does a respiratory therapist do in this multidisciplinary clinic? Let me first thank the team for letting us be part of this program, because it is really a privilege for me and my team. Actually, we are 3 from respiratory who's joining this clinic. So let me walk you through briefly of what our roles are in this multidisciplinary clinic. So basically, picture out that we are in the room with the pulmonologist and the ENTs. We assist them in whatever needs, respiratory-wise or in tracheostomy, that they may need. So obviously, we are dealing with tracheostomy patients, with tracheostomized patients. So what we really do is, if it's deemed necessary during that time, we do the trach changes as ordered by Dr. Basha or the other ENTs. We do it, or we assist the ENTs, or we assist the families in doing it, together with the education that we are giving to them. So during this clinic as well, we do speaking valve trials. So if SONA is not able to do it, or it depends upon the turnaround of the clinic, we do it just to start and then teach the family as well. So during this clinic, if it's deemed necessary as well that the physicians are thinking that the patient is ready or will be ready for the cannulation, we do the capping trials. So dear colleagues, I know that you're fully aware of what the capping trial is. So we do this with the parents, we do this with the carers, so that the patient can be ready in fully decannulating the tracheostomy tube. During this clinic as well, we see patients who are on CPAP, non-invasive ventilation. We see patients on BiPAP therapy. We do the mask fitting. We see if the settings are correct. We see, the compliance of each of the patients that we are dealing with. We see ventilated patients as well. And if the Dr. Sophia wanted us to do some change in the settings based on the blood gases, we do that. And also, we check the home equipment. So we serve as somewhat the biomed of the team. We do the checking of the machines that they have, if the PPM has been done, and all the equipment that they need, especially the consumables, when they are at home. So I'd like to give emphasis on my last slide. So as a take-home message, as respiratory therapists of this team, we educate, and we educate. We take this chance that whatever lapse, whatever gaps that the patient, the carer, and the family is having at home, we do support. So this is a one-time clinic, but we see to it that there's a follow-up in respiratory diagnostics. And with that, I end my slide.